Good afternoon, everyone. Welcome to our quality breakout session. The abstracts that we will be being presented today all kind of coalesce around the theme of improving quality and safety by having better patient-centered care. And I hope that everyone here finds the content really useful and that we have an engaging discussion. So I'll introduce our first speaker. The paper is titled Patient-Reported Outcomes in Pain Management After Ambulatory, Pediatric, General, and Urologic Surgery, Utilizing Opioid Stewardship Strategies, and is being presented by Dr. Devin Pace.
Hello, everyone. Thank you all for coming. I'm excited to present today, so we'll have a little bit of chat here. Is this? Do you know if there's advances here? Do they have, is it just this right here? Oh, right click, all right. Here we go. I have no financial disclosures to report. Thanks. So the opioid epidemic remains a critical public health issue in the United States, and the pediatric population is just as susceptible to its effects. Around 60% of pediatric patients develop, fill opioid prescriptions postoperatively, and up to 5% develop persistent opioid use behaviors as a result of these prescriptions. It is important as surgeons and patient advocates to minimize the number of opioid prescriptions postoperatively. Currently, there is significant variation among opioid prescribing practices across institutions and procedures. On review of the pediatric literature, stewardship interventions generally assess emergency department visits or readmissions as the primary outcomes for uncontrolled pain. And this research is limited to procedures which already have extremely low return to system event rates. In addition, there's limited research that assesses patient-reported outcomes in pain management, and this is likely a more complete assessment of the postoperative experience. At our institution in January 2017, there were department-wide efforts to reduce the number of opioid prescriptions postoperatively through provider education sessions. These were composed of informal discussions during our weekly meetings around the negative effects the opioid epidemic has on the pediatric population. Surgeons were ultimately encouraged to minimize or avoid opioid prescriptions altogether on discharge. In addition, our anesthesia department had a separate effort where they were educating patients postoperatively on the effective use of non-opioids for multimodal pain regimens. Given these changes, the goal of our project was to evaluate the number of opioid prescriptions before and after provider education, as well as ensure that postoperative pain was adequately controlled after an expected reduction in the number of opioid prescriptions. We performed a retrospective chart review from 2015 to 2019, evaluating the procedures listed for patients that had pain scores and evaluated whether or not they had opioid prescriptions on discharge. We reviewed a total of 2,033 charts, 493 pre-intervention, and 1,540 post-intervention. This is a statistical process control P-chart that evaluates the frequency of opioid prescriptions over time. As you can see, after our intervention in January 2017, there was a significant reduction in the number of opioid prescriptions, and this was successfully sustained over a 2-year period. The proportion of opioid prescriptions was reduced substantially from 45.8% to 7%, and this was a 6.5-fold reduction. In regard to pain control, we interestingly found that those in the opioid group reported significantly more moderate or severe pain than the non-opioid group at 14.1% compared to 10%, and this was statistically significant. This chart demonstrates stratification by procedure to account for procedural variations in postoperative pain. Similarly, you can see every procedure did not have any higher reports in moderate or severe pain among the non-opioid group, which further demonstrates similar postoperative pain with non-opioid regimens. Additionally, there were no ED returns or readmissions related to inadequate pain control among the entire cohort. So I think this begs the question, do opioids really result in worse overall pain control? We were surprised to see that the opioid group reported significantly more pain than the non-opioid group. Listed are some possible explanations. As mentioned previously, our anesthesia department began providing education on the proper use of non-opioids for multimodal pain regimens. It's possible that this intervention resulted in improved pain control, and patients had less chance of developing moderate or severe pain. At a similar time, our regional anesthesia usage as an institution increased significantly. It's possible that this resulted in improved immediate postoperative pain. However, it's unlikely that this effect lasted long enough to impact pain scores at 24 to 48 hours after surgery. Lastly, we did not stratify procedures by the degree of invasiveness, and it's possible that those patients who had more invasive procedures were more likely to be prescribed opioids and report moderate or severe pain. In general, all of these factors may contribute to the results and suggest that opioids had worse pain control. So I think overall, provider education interventions are simple, yet can be extremely effective in the appropriate setting. Opioid stewardship strategies can be applied to numerous outpatient procedures without compromising pain control, and it's important that we continue advocating for non-opioid regimens. Most importantly, we should continue to seek patient-reported measures to gain a better understanding of the postoperative experience, rather than systems measures, as this may provide a skewed perspective for those procedures that already have limited return to system rates. Lastly, we should continue to advocate for non-opioid regimens overall. I think that's probably the main takeaway from this presentation. Additionally, further research is needed to identify additional procedures that may be amenable to non-opioid regimens alone. Lastly, we can continue to expand our understanding of patient-centered measures through the utilization of artificial intelligence. Currently at our institution, we're piloting a texting-based platform that administers surveys to patients postoperatively to evaluate our measures that we had discussed previously. In addition, this allows us the ability to respond in real time via text to patients that are concerned about overall uncontrolled pain. Thank you everyone for your attention. Listed are my references, and I'm happy to take any questions at this time.
Thank you. Next, I'd like to invite Dr. Derek Wakeman to open up our discussion. He's the discussant for this paper.
Dr. Pace, thank you very much. I really enjoyed reading your manuscript, and I was really particularly struck by your control chart and just how profoundly you changed opioid usage at your institution. I was wondering, you talk about educational sessions. Was there anything else that you guys did, anything else your hospital did to contribute to that dramatic decrease? Because I think really the process is what's important, and anything else you can share with us would be helpful.
Yeah, I think that's a great question, and this is something that we kind of talked about a lot around the time of the project. So historically, when we think back to when the intervention was actually implemented, there's a lot of data coming out about the negative impact of opioids actually have on patient care. And so, within our own department, we had just this single intervention, which, I want to highlight, with such a simple intervention, we had such a profound impact, but I don't think this effect was just related to us alone. And so I think anyone who's trying to implement protocols in general, needs to take a multi-departmental approach, and I don't want to, minimize the effort that anesthesia put in as well to educate patients postoperatively. So that's where I actually think a lot of the results actually came out was the collaboration between the groups.
Thanks, and I was also struck that the patients who were prescribed opioids in many cases had more pain. I was curious, those who were prescribed opioids, were they also told to similarly take acetaminophen and ibuprofen or other NSAIDs?
Right, so that was another thing that we had attempted to consider as well, and I think before 2017, we didn't necessarily have like a formalized protocol on what we were telling patients postoperatively, although the surgeons in our group do advocate for non-opioids and probably did before that time. I think after 2017, regardless of the prescription that patients got on discharge, they were all educated on the proper use of non-opioids, or they were actually prescribed non-opioids on discharge.
And then lastly, there's a suggestion that opioids were more commonly prescribed after circumcision and orchopexy, which can be considered urologic procedures. I'm curious, at your institution, are those procedures that the pediatric urologists are doing? And if so, are there any efforts to try to get this message more to those folks as well? Yeah,
so in general, I think, the pediatric surgeons at our institution generally do those procedures for patients that are younger. Patients who are a little bit older tend to be done by the pediatric urologist, but I think at the same time, if we consider, who are the patients that are getting the opioid prescriptions, which we also mentioned in the manuscript, but, a lot of those patients were older in age, and so I suspect those were the kids that were also getting prescribed opioids at that time. However, we do have an opioid stewardship committee at the hospital that is working to identify areas where we can really improve our opioid usage. So this is one area we're looking at, and we're just hoping that this project, really expands on that data to show that non-opioids are just as adequate.
Yeah, thanks again. It's tremendous work, and I just remind the audience that the opioid epidemic has gotten even worse during COVID.
Thanks.
Dr. Pace?
I don't want to distract from the nice work you've done, but opioid reduction using multimodal strategies is part of enhanced recovery after surgery. Had you considered linking your opioid reduction efforts to a coherent protocol that already exists in your institution with colorectal and maybe other places to help galvanize people's attention? Because what you're doing right now, just doing it by yourself, is a heavy lift. But when you attach it to a well-functioning protocol, it might be a nice asset for you.
Yeah, I think that's an excellent point. And I think that's, probably the main reason why this opioid stewardship committee, which is kind of relatively new in terms of becoming more organized, I think that's the ultimate goal, is to make sure that, all providers across multiple different specialties are on the same page. And so, I could definitely see in the future that, that being the standard protocol is just implementing an ERAS for, especially different procedures, especially for pain control. Any other questions?
I have one quick question.
Yep.
I liked how you broke it down by the type of operation, but did you also look at it by individual surgeon? Were there certain surgeons that prescribed opiates and other surgeons that didn't?
So we actually didn't look at it on a surgeon-specific basis, but I agree that is definitely something that we can look at as a department.
Yeah, that might be a way for you to have, you showed really nice sustainability of after your intervention, your initial intervention. Perhaps if you had more, focused feedback to individual surgeons if needed, or maybe re-education. I wasn't clear how many times you had to engage the faculty with the initial education, or re-engage, I should say.
Yeah,
That would be
it's
a match.
to my understanding, it sounds like there was a few interventions right initially around that time frame, and then there was just a consensus agreement among the department to minimize or reduce opioid prescriptions.
Very good.
All right, thank you.
Okay, thank you. I'm Kirk Reichert from the Moores. Welcome this afternoon. Our next talk will be given by Dr. James Frazier, representing the group from Children's Mercy in Kansas City, evaluating caretaker satisfaction with same-day discharge after gastrostomy tube placement. James?
All right, good afternoon. Thank you very much for allowing us to present our work. We have no disclosures. So gastrostomy tube placement is among the most common surgical procedures performed in children and the focus of many quality improvement projects due to a disproportionately high pre- and post-operative resource utilization and cost variability. So differences in management based on provider preferences and patient comorbidities have resulted in multiple individual institutional protocols, with many focused on expedited discharge to decrease cost and the subsequent resource utilization. So with the adoption and success of these ERAS-type protocols, although there have been improvements in areas such as cost, reduction in opioid use, and more expeditious discharge, parental opinions and parent satisfaction are infrequently addressed. Our institution has utilized the same-day discharge protocol after elective laparoscopic gastrostomy tube placement as standard of care since 2017. It emphasizes early initiation of postoperative feeds and comprehensive preoperative education to prepare for this same-day discharge. And although we have improved metrics such as time to initiation of feeds and length of stay with minimal complications, the caretaker perspective, experience, and satisfaction with our same-day discharge protocol has not yet been evaluated. So in our study, we looked at all patients under 18 years of age who were planned to undergo same-day discharge after G-tube placement from February 2021 to February 2022. Telephone follow-up at 2 weeks postoperatively was performed to evaluate caretaker comfort and satisfaction with the same-day discharge protocol. Chart review was performed to identify demographic information, the rate of successful same-day discharge or reason for postoperative admission, the time to postoperative feeds, length of stay, and complications. 49 patients in total were eligible for our same-day discharge. 42 were successfully discharged, and 7 were admitted for either postoperative emesis or further teaching. Of the 86% of patients successfully discharged the same day, the median length of stay was 7.5 hours and 30.4 hours for those who were admitted postoperatively. The median time to the first feed was similar between both groups at around 2.3 hours. In total, 8 patients, or 16%, were evaluated in the emergency department within 30 days postoperatively, 5 within the same-day discharge cohort, and 3 in the postoperative admission cohort, with 2 readmissions for surgical site infection and gastrostomy tube dislodgement requiring operative replacement. On 2-week telephone follow-up, 42 caretakers felt that their education was adequate for same-day discharge and stated that they felt comfortable with the same-day discharge protocol. 6 caretakers, or 14%, stated that their child's pain was not well controlled at some time between discharge and postoperative follow-up. And 3 caretakers, or 7%, called their primary provider or the surgery clinic within 24 hours for issues with pain, which was well managed with non-operative or non-narcotic recommendations. 41 caretakers, 98%, expressed satisfaction with their decision to go home the same day, with 1 caretaker describing the process as too quick. She expressed concern that her child had 2 episodes of emesis within 24 hours of discharge. However, this patient did not require further evaluation or readmission postoperatively. So our data highlight the feasibility of same-day discharge after laparoscopic gastrostomy tube placement and high parental satisfaction with our same-day discharge protocol. We observed a low rate of readmissions or postoperative issues, and also demonstrated areas for improvement, including pain control after discharge. Interestingly, we found an improvement in the efficiency of our postoperative pathway, as demonstrated by a reduction in the length of stay for our same-day discharge patients from our initial prospective analysis in 2020, from 9 hours to 7.5 hours, and a reduction in the time to first feed, 2.3 hours, from an initial 4.4 hours. So parental and caretaker satisfaction has been assessed in a minority of studies focused on ERAS-type protocols in the literature. For example, a 2021 meta-analysis assessing the outcomes of pediatric surgery ERAS protocols that reviewed 16 studies and a total of approximately 1,700 patients. Only one of these studies addressed parental and caretaker satisfaction. As the pediatric surgery community moves towards less resource-intense, more cost-efficient practices through implementation of these ERAS-type protocols, including the caretaker perspective in protocol development and implementation is pertinent. Validation of caretaker satisfaction with same-day discharge or expedited discharge protocols should be a necessary component to protocol implementation. There is great value in assessing not only the comfort, but areas of improvement that is usually best characterized and evaluated by caretakers themselves. Without inquiry of patient and caretaker concerns, evaluation of these protocols should be considered incomplete. So in conclusion, our same-day discharge following laparoscopic gastrostomy tube placement is feasible. It's more efficient with increased institutional experience and has a high caretaker satisfaction. And this is ascribed to comprehensive preoperative education and anticipatory guidance.
Dr. Monica Lopez will open the discussion. Oh, I'm
Dr.
sorry.
Raquel
Gonzalez.
Gonzalez.
Raquel Gonzalez, I'm sorry.
That's okay.
Long day.
First of all, I want to commend you for your work, right? It's very important. It's a common procedure, right? It's very important to us. It has institutional variability despite protocolized care. Moreover, like you said, right, we don't necessarily address parental concern, which is pivotal to patient-centered care. One of my first question is, who provided that education during that first clinic visit, and how long were you allotting to that clinic visit? Because there was video education and hands-on care, and so we know resources are scarce. So who was doing that? And along those lines, who was providing that education in the inpatient side when the parents requested additional education?
So thank you for your question. We have a very comprehensive clinic. When patients present electively for consultation for an elective G-tube placement, our nurse practitioners usually provide the education that the parents need. It's both video-based and they have paperwork. They can use a teach-back method with a doll. I'm not sure of the length of time for the appointments. On the inpatient side, the nurses that we have in the unit that these patients get sent to post-operatively are very well versed in the protocol as well, and they're very familiar with it. They always do education regardless to say, are you comfortable with the feeds? They allow the parents to do the feeds and administer the first feed if they'd like. And we always tell the parents, if you do not feel comfortable, you do not have to go home. Just because that's our protocol, it doesn't mean that you have to go home. So it's primarily nurse-driven and nurse practitioner-driven in terms of the education.
Awesome, awesome. For two patients that were admitted, one on post-op 21, post-op day 29, was there any information that you could have sensed from the 2-week telephone conversation that could have hinted that there were some issues going on those two particular patients?
Yeah, good question. So I did look back at that. There was nothing that the caretakers expressed that they had any issues with any of the feeds. There was a phone call, I believe on day 18, for the patient that came in with a surgical site infection that they noticed that the area started to become more erythematous. But that's not uncommon for a patient with a G-tube when they call in. There wasn't really anything that we could point to at that 2-week visit that said this patient's probably going to come back or that this patient's going to have a complication.
And then my last question is, as a quality improvement initiative, you mentioned that there's some refining that you was going to take place. Have you guys addressed that? And one particular question that came to my mind was, for those 4 patients that requested further education, what was the time span between the actual education in the clinic and the actual OR day? Was that influential in terms of them needing more education, because a lot of time had elapsed?
Yeah, so the median time to when that education was provided to when those patients were operated on was about 11 days from their initial visit to the operation. Our study is ongoing to identify areas that we do need to improve aside from just post-operative pain. Looking specifically at factors of which patients are going to need to stay for further education are those the parents who, they don't have another child with a gastrostomy tube at home. Those, we had about, I think there were 2 patients from that 4-patient cohort where the parents had no experience at all with a G-tube. They said they felt comfortable, and then they saw the feeds being hooked up and they asked, would you mind if we just stayed? And our protocol says that's perfectly fine.
Sure.
Yeah.
Well, awesome, strong work. Thank you so much, and I encourage you to upload it to our quality and safety
Yep.
toolkit. Thank you so much.
Yep.
Length of stay is your kind of dominant metric. You have to have a balancing one. So you reported on return to the systems. What did you learn from the failures? Was it an education problem, or were there discrete things that would help you with your protocol and your process? And then I guess the second question I have is, when you referenced enhanced recovery a couple times in your introduction, when this was brought to pediatric surgery at the very beginning with the German group in Hanover, they reported on patient satisfaction on all their stuff, and parents loved enhanced recovery. Are we going to have to measure that on all the protocols in the future to make sure the parents are still loving it since they did 15 years ago?
Right. Thank you for your questions. So to address the first question, looking at improvements and stuff that we've learned from the patients who we qualify as not going with the protocol or failing the protocol, refining the education and identifying what parts of the education that the parents felt uncomfortable with or the caretakers felt uncomfortable with, that's going to be the primary goal going forward. We didn't identify anything uniform between those 4 patients that required a post-operative admission for the further education. And then to address your second question, yes, I do think that parent and caretaker satisfaction needs to be assessed for protocols that we're implementing. As surgeons, as physicians, we love the protocols that can either expedite discharge safely, or we see benefits on our part it's not always apparent to see what the caretakers and the parents experience unless you're actually following up and saying, do you like this? The issue that we have to address is parents can go online, look at, if you type gastrostomy tube placement in online and the parents read something that it's a 2 to 3 day stay, and your center is saying that they can go home the same day, you need to explain to that patient what you're going to do to address their concerns. You need to explain to the patient what you have in place to address issues that may come up. And then you also need to provide that education to make sure that the patients are comfortable. You also need to follow up to make sure that when the patients go home, and not immediately, in 2-3 weeks, to make sure that in that time span that they were home, that they really did feel comfortable going home at that time.
Hi, Jill Whitehouse, Hollywood, Florida. Congratulations. I'm literally going to take this back home with me. I have 2 logistic questions, purely logistic.
Yep.
How the heck did you do that? How do you get the pump, the supplies, the home health care? How is that set up before you do the surgery? 95% of our patients stay because of that reason.
Yeah.
In fact, if we do a G-tube on a Friday, I tell them the chance of you going home this weekend is slim to none.
Right.
That's question number 1. Question number 2, where are they for those 7.5 hours? Do you leave them in the PACU? Do you have an extended stay? How do you do this? That's what I'm asking.
Thank you for your question. To address the first one, at the time of consultation, a referral to the DME company is made and social work is made aware. The patient will not go home unless everything is set up. So if on the day of surgery we see that the pump is not sent home, if they require the pump for the feeds, if it's not set up, we will not send them home. Everything needs to be in place before we continue with the protocol for that patient. So the referrals are all made at the time of consultation. So social work, the dietitians, and the diet plan is made. That order is put in so that the day of the operation, everything is released. So the formula, the feeds, whatever the patient needs is going to be ready. So the second that they leave the operating room, the order is placed and it's brought up to the unit. Your second question, we don't have a special unit for these patients. It's technically an extended stay unit. It's not necessarily the PACU, but a unit where the patients can stay a little bit longer than patients would in PACU. And for those 7.5 hours, the nurses are making sure the feeds are going well, making sure the parents are comfortable. And then once they're comfortable and the feeds go well, we send them home. So it's a separate unit, but not just for these patients.
And I had 2 quick follow-ups, James. The first is, was anybody going home the same day before the protocol started? And if so, what was the barrier before your protocol was in place to prevent people from doing that?
So prior to the implementation of our same-day discharge protocol, I do not believe patients were going home same day. Sorry, what was the second question?
What was the barrier for them not going home? Did you change more than?
I think we just expected that the patients had to tolerate either their full goal feeds before they left, which in our protocol, we've had some patients leave at half of their goal feeds to up to 1/3 goal feeds, depending if they're bolus feeds, if they're continuous. So primarily it's the feeding issue of making sure that they can tolerate their goal rate, and I think that was the barrier to sending them home the same day.
Thank you. Any further questions?
I have one quick question. Does your group use T-fasteners or sutures, and if so, when do you remove them?
Sutures, and they can be removed day 5. We do give the parents the ability to remove them. We teach them how. We haven't had any complaints about that. I haven't heard from any parents that that was an issue. We also give them the option of going to their pediatrician to follow up, and sometimes the pediatrician takes them out. Yep.
Great presentation. Thanks.
Okay, our next presentation will be in the virtual format. So this presentation is entitled Adolescent Experiences in the Safe Surgical Checklist Process. And it will be presented by Saad Sunba, who's a medical student, University of Calgary. Following the presentation, Dr. Morgan Richards, who's present here, will be leading the discussion, which was pre-recorded as well. So we'll just watch the whole thing, but I would welcome the audience engagement afterwards. as well.
Hi everyone, my name is Saud Sumba. I'm one of the final year medical students at the University of Calgary, Canada. Thank you so much to everyone at ABSA for allowing me to present to you today the adolescent experiences of the SAFE surgical checklist process. Surgical processes have been evaluated across the age spectrum. We have studies on infants, children and adults, and the elderly. However, fewer studies focus on the adolescent population. No studies have actually looked at their perceptions through key surgical processes. This is the first study of its kind that has engaged adolescents to understand their perceptions, satisfactions, and needs in key surgical processes. We used qualitative methodology to examine their experiences with surgical consent, the safe surgical checklist, and the post-operative care. We purposefully recruited 10 patients aged 13 to 17 undergoing either elective or emergent surgeries at the Alberta Children's Hospital, which is a freestanding tertiary hospital in Canada. Our interview scripts were co-developed with an adolescent patient advisor to ensure the questions were appropriate for the adolescent population. All the interviews happened after their surgical stay. Several themes emerged through a grounded theory approach of analyzing the interviews. And what some of the most common themes have been: first is the autonomy and inclusion, second is the repetition of information, and finally it's the importance of transparency. With the first theme, what we found is that adolescents desire to participate in the consent process, including signing their own consent form when appropriate. These themes of autonomy and inclusion were predominantly identified as important to adolescents during the preoperative stage and during the consent process as well. Interestingly, 60% wanted to sign their own consent and 40% were comfortable with asking. As one participant put it, well, since I consented to surgery, I didn't feel I needed to sign anything. I was pretty confident with the ability of the doctor, so it was fine with having my parents just sign the consent form. What this highlights is that adolescents want their voice to be heard and they want to make the decisions regarding their bodies and their health. However, it does not matter as much to them having to sign the paperwork or the legalities associated with it. With the second theme, what we found is the adolescents value repetition of information in the preoperative check, and they feel safer meeting the team. So this process where they were asked a lot of questions, they recalled that they were asked questions, that they were meeting the team. However, 80% of them did not recall the specifics of the checklist. As one participant put it, they asked me the same questions a couple of times to reassure the answers, and then they went over it with me too. They repeated back to me so everything was clear about things like my allergies and my consent and stuff. What we found is that adolescents truly felt safer and they felt more involved as part of the process, that everyone was repeating information, everyone knew what they were doing, and that in turn made the patient feel a lot better and a lot safer. And finally, the third theme that emerged is the importance of transparency and communication. This was subdivided into two sub-themes: the caregiver involvement and transparency with the patient. What we found is that adolescents want to know everything about their surgery, things about the surgical procedure, ideas about the post-operative stay, the prognoses, complications, all of that they wanted to know beforehand. As one participant put it, in the bolded sections, like, I want to do things my way and only my way and all that good stuff, but at that kind of time, like right before a surgery, like I want my parents to be the ones that are more involved. So what we recognize is that adolescents themselves recognize that they want to make the decisions themselves. They're at a stage where they're comfortable making these decisions. However, at these high stress situations, ones they may not have been a part of before, they want their parents or caregivers around them for support. The study does have limitations, is that all the interviews and all the surgeries were done in a single institution. Social determinants of health were not assessed given the type of sampling. And finally, we did not actively seek patient representation, such as different socioeconomic status. In conclusion, adolescents desire to be involved. And we can do that through respecting their needs for autonomy, incorporating them into the safe surgical checklist and sign-in, incorporating the parents into the discussion, but having the primary focus on the adolescent, and then finally maintaining clear communication. Thank you so much.
Hi, my name is Morgan Richards, and I'm a pediatric surgeon in Boise, Idaho. Thank you very much for sharing your work with us. This is an interesting and relevant topic as we continue to focus on patient-centered care. In our case, as pediatric surgeons, that dynamic is complex since our patients are part of a family unit. This is a useful study as it focuses on what is important to adolescents undergoing an operation. I have a couple of questions for you. First, I appreciate the emphasis on allowing autonomy and allowing patients, even adolescents, to make their own decisions regarding their bodies. But what do you suggest if an adolescent patient who is not an emancipated minor does not consent to a life-saving procedure? How should we proceed if there's disagreement between caregiver and patient?
Yeah, thank you so much for that question, Dr. Richards. That's a really complicated situation. What we need to recognize is that they're children at the end of the day. I think if we were to take a situation where we have a small child who's gone through multiple surgeries and they're tired and from the long surgical stays and their outcomes are not good and they understand all of that and they don't want to take that next surgery, is quite different than a 14-year-old who's scared of having an appendectomy and it's their first surgery. What I think we need to do is have a discussion with the patient and assess their competency in this case. We recognize that not all teenagers can act in their own best interest. And then ultimately what we want to do is help adolescents be co-decision makers with their parents or caregivers. We recognize that they're more children than adults in this case. And that what we found in the study is that during these high stress situations, the adolescents want their parents to be involved. And then by having their parents be involved and have that triangle discussion between the patient, the caregiver, and the physician, relaying ideas and having that discussion is the best way moving forward.
Thank you for that explanation. My second question is, what are your plans for this work? Do you feel that additional qualitative work is necessary, or do you think that this informs either a retrospective or prospective study design based on your findings? And how do you think the addition of focusing on socioeconomic factors, race, ethnicity, gender, etc., may influence future results? Again, thank you so much for your presentation.
Yeah, I'm happy to take on that question as well. Thank you so much, Dr. Richards. This study is actually part of a larger study examining the Safe Surgical Checklist. We hope to create a future study that helps to plan a change for the Safe Surgical Checklist so that it's more inclusive for the adolescent population. Piloting that across multiple centers to see how they respond with that change and assessing their perceptions will be a future step for this work. With regards to your second question, we truly recognize that we have not included patients that might represent marginalized groups. And so we might be missing some of the nuances that they experience with the healthcare system. We recognize that children from varying racial, religious, socioeconomic status, and patients from diverse gender backgrounds may have different experiences that warrant further exploration. We have seen that in the adult literature where patients from lower socioeconomic status experience worse health outcomes. So it would be very interesting, very important to study that in the future with the adolescent population and including a group of marginalized population as they go through the Safe Surgical Checklist process and analyzing their thoughts and perceptions so that we can learn best how we can move forward and make changes so that we can become inclusive to everyone there. It would also be really important to compare and contrast the findings from that study to the current results that we talked about today so that we can, again, create a more inclusive experience and that all adolescents have a positive perception of their surgical stay. Thank you so much. And thank you so much to everyone at APSA for allowing me to speak with you today.
Dr. Richards, do you have any additional commentary? Anyone in the audience, any comments? If not, we can forward those questions or comments by email to our presenter. Thanks.
Okay, I think we're ready for our last presentation. This will be by Dr. Lawrence Willis and the group from Le Bonheur Children's Hospital, entitled Readability of Patient and Family Education Materials on the American Pediatric Surgical Association website. Dr. Willis.
Thank you for allowing me the time to present today. I have no disclosures to present. All right, so health literacy is the basic reading and mathematical knowledge that is needed in order to participate in the health field. studies have shown that patients with high health literacy are more likely to have better health outcomes. That includes being able to adhere to medication regimens, attend all scheduled appointments, and participate in the treatment team. The inverse is true for those with lower health literacy in how they have lower health outcomes. The good thing is that health literacy can be improved by presenting materials at the level of the patient. So that gives us to readability, which refers to the ease in which written text can be understood by the population. In the US, 80% of Americans read at the 8th grade level or below, and therefore the NIH recommends that any medical materials be presented at the 4th to 6th grade reading level, which brings us to the APSA website. So the website actually has patient materials that regard a bunch of different surgical conditions. Our goal was to analyze these materials because our hypothesis is that the materials are presented at a readability level that is above the recommended level. And so what we used those publicly accessible materials on the website, and we analyzed the readability of those materials using online readability tools from the readabilityformulas.com to perform multiple grade level assessments and readability assessments. So we used 5 different formulas, which include the Flesch-Kincaid reading formula, the Flesch-Kincaid reading ease, the Coleman-Lau index, and the simple measure of gobbledygook, otherwise known as SMOG, and the Lasper-Heitz Swedish readability formula, otherwise known as LIX. So the Flesch-Kincaid reading level is based on the average sentence and length of average syllables per word. Our assessment showed that the average materials was about at the 10th grade reading level, and only about 5 of the topics were at or below the 8th grade reading level, as you can see in this graph here. For the SMOG index, this assesses the number of polysyllabic words in a passage to present a grade level reading equivalent. And in this case, all the materials were above a 10th grade reading level. In addition, most were at a college level, as you can see here. So the Coleman-Lau index assesses the usability of a text based on the average number of letters and average numbers of sentences per 100 words. And this was initially used to calibrate textbooks for US public schools. Our assessment showed that all the topics were above an 8th grade reading level, and some were also a college level reading as well, as you can see here. So the Flesch reading ease uses a similar as the Flesch-Kincaid, but instead of a grade level, it uses a score that determines how easy a text is to read. Higher scores equal easier text in this case, as you can see here. So the LIX formula uses the percentage of words that are greater than 6 characters and the average numbers of words per sentence. This was used to measure the readability of text in a foreign language. Our assessment showed that an average to a high level of English is needed to understand the text on the APSA website. And in this case, smaller scores equal easier text. For some study limitations, including, we only used 5 of the different formulas. There's dozens of different formulas that can be used that offer different various results. And the APSA materials are only available in English. So we used the LIX formula to kind of infer how difficult it would be for somebody in another language to understand the text on the site. And the readability assessments only measure written text. So we didn't analyze if pictures can contribute or detract from the understanding of the text. And we also did not engage patients or families in how they can comprehend the text in our study. So conclusions, the majority of the patient-family education materials associated on the website are above the recommended level associated by the NIH. And so we hypothesized that the website may not be meeting the aim of navigating the issues regarding these surgical conditions. And so APSA should reconsider writing the materials with an emphasis on readability, as well as presenting materials in languages other than English. Thank you. That concludes my talk.
The discussion for this paper will be opened by Dr. Matthew Santoro.
Dr. Willis, thanks very much to looking into this. This is very important for education for the families. I appreciate that you looked at the 5 most common formulas for looking at readability. One thing when I was looking at the website I noticed, which you noticed, is that they're all in English. There's one very good video, but there's only one video on hernias. If you were to take this and say you had unlimited resources, how could you make this better? What would you do?
Thank you for that question. I think the thing is, one, we need to make sure that more people have access to this, so creating different languages, so getting people who speak the language for whatever different hospital has, whatever the patient population in that particular region, whether it's Spanish, Mandarin Chinese, which is kind of in our, at least my home institution. In addition, I think more studies need to be done on how visual aid can either detract or adhere to readability. I think most people like having pictures and like seeing, especially when it comes to surgeries, like having kind of a visual aid of what things go on. So that's at least how I would begin to address that.
One thing I was doing when reviewing this, I was actually Googling some of these conditions, and ABSA didn't come up in the top searches. Is that important for ABSA to be in the top search for Google when other institutions are going to be the top search? And is it okay that, say, another hospital or a hospital has the top search for the different conditions? Or should ABSA be leading this, making sure that we are the #1 search?
I think in terms of whether the searches are addressing the need in terms of understanding, my manuscript kind of expands upon it a little bit more, that regardless of the area, a lot of the conditions are still above the recommended level. So I think if we were the ones to kind of pioneer kind of really trying to get the readability at a level of the general population, I think that can kind of cause a domino effect for other institutions.
And then my last question is kind of sort of along the lines of the last question is, do you know how many times this website's been visited?
Unfortunately, I do not. I think there are ways to kind of detect like the traffic of a website, but that was not part of our study.
Again, Dr. Willis, thank you very much. I think this is very important and something that needs to be addressed, so thank you.
I have one quick question. I'm curious, have you applied this rigor to things on the Labana website, and what did you find there?
So we haven't yet applied the assessment to the Labana website. I think one of the things that we want to do over the next year is kind of engage the actual patient population, first to see their engagement and then kind of go from there. So we need to have like a baseline of where the people in our encatchment area stand first.
It's a great paper. Maybe we should put those resources up on the toolbox also. I'd be curious what our website looked like. Another question?
This is great feedback. Thank you for sharing that with us. I can only respond on behalf of the dozens of pediatric surgeons who have been trying for decades to write like 6th graders. We just don't do it very well. Good or bad, we just don't. But this is really, really helpful information. To answer your question, this site is looked at thousands of times per year. So it is something that our patients and parents are finding valuable, and we should do a better job of making it understandable for them. Based on your expectations, my question is, since we as pediatric surgeons don't write very well as 5th or 6th graders, did you find any tools like your evaluation tools that could help us learn to write as 5th or 6th graders?
So I think one of the things that we are doing in terms of getting more engagement and having patients kind of understand what's going on, we have like child life coordinators that are associated with some of our ERAS protocols. So at least for that particular set of patients, we are doing things that are kind of more at the level of the kids. We have a lot more visual aids. We try to use less words as we possibly can to kind of help them understand what's going on and what the next steps are. But we haven't quite expanded it to the general pediatric surgery population quite yet at Le Bonheur.
Thanks again for the feedback.
Any other questions? Then that brings this session to a close. We invite everybody to join us for the poster session at 5 o'clock and for some refreshments. Thank you.